a lot of information and background that we came up with, the collaboration within the maternal hemodynamics working group, which is a very special field, which like really conquered my heart. And I would like to share with you here some of the journey that we gathered the past years. And I always like to start with this flat line. And normally I try to make it interactive, but in this case it's quite harder. So I'm just giving you a second to just think about what this flat line would imply. And I'll give you some hints. It maybe implies a lifeline, as you can see here, with at some time there's birth, and there's illness, and then there is death, which is quite not a very sophisticated lifeline, and which in my perspective represents the lifeline of a male without many suspense happening in between, except probably a midlife crisis around, well, that age, which could easily be solved with, I hope, a car. But of course, it's not so simple, but I'm trying to make it that simple because I want to switch directly to the lifeline of a woman, in which many biological events may affect her lifeline, but also the lifelines of the other humans that come through the woman. So in this case, a woman also gets born at a certain time, which is the only characteristic with is for 100% correlated with death at a certain point, obviously. But there's also the pregnancy, which is a huge life event. Well, if it's not getting complicated, but when it is getting complicated, it has a lot of implication. And then there's a second pregnancy, the menopause. And all of these might be so obvious in your heads as obstetrician that you continuously work around these life events. While I think they are not only important for obstetrician, but at least as important for clinicians working in the cardiovascular field. And why that is, well, there are many reasons for that. Let's start with a very simple but very important finding of more than 20 years ago, that the meta-analysis of Bellamy and also many other studies that showed that preeclampsia was a risk factor for cardiovascular diseases, and in general cardiovascular diseases, but specifically for ischemic heart disease and ischemic cerebrovascular diseases. And beside that, other studies came up and they showed also a large association with heart failure, arrhythmias, and many other disorders. So in this case, let's rank the risk ratio for preeclampsia among other risk ratios for other risk factors, which we are very familiar with when we are doing our cardiovascular assessments, which you can see here. I put preeclampsia here above, and then if you see the range of obesity, smoking, hypertension, three of our most important risk factors that we have to deal with in our clinical practice, well, preeclampsia is among that range if you take preeclampsia as a whole, early, late, single, recurrent. So it has a risk ratio of 2.2 associated with ischemic heart disease and ischemic cerebral vascular disease. But when you focus and zoom more into the early preeclampsia, which was done, then we reach a risk ratio of 7.7, which it wins from all the other risk factors that we are dealing with, and only familiar hypercholesterolemia has a higher risk ratio than early preeclampsia. And yet, I think we do fail in clinical practice to take that as a risk factor to deal with after those women have had preeclampsia. And there, I'm sure there's a large range among countries, among regions, among hospitals, because in Maastricht, of course, we have a very dedicated center. So we have a huge focus on assessing those risk factors in these women, but there are a lot of centers who don't have this focus and then fail to provide the follow-up necessary for these women. So what do our guidelines say? Our European Society of Cardiology guideline. What should we do with these women? Well, there is a 2A level of evidence for women with a history of preeclampsia and or pregnancy-induced hypertension for periodic screening for hypertension and diabetes. This should be considered. And actually, that's pretty much it. What should we screen of? When should we screen? What should we do whenever we see some abnormalities that might not reach the clinical cutoffs for example, hypertension or heart failure? Should we treat them earlier? So it leaves us with a broad range to fill in ourselves as clinicians. And there are suggestions that hypertension would be the prior risk factors to focus on. And as you must be aware of, like the prevalence of hypertension is quite high after preeclampsia, and not only in the first 12 months after delivery, but also if you are hypertension free in the first 12 months, there's still a very large odds ratio of developing it after a year and also after 24 months, so after 2 years. So even if you're hypertension free after delivery, the risk of developing it later remains very high. And why is that a very important finding, actually? Well, I think it's not new information if I say that hypertension is actually one of the largest silent killers that we know, because you often don't have complaints that are related to hypertension unless there is end organ disease, which occurs like years later, or when hypertension becomes so severe that it becomes like life dangerous. So then you're again way too late. While in the years before it reaches that stage, it still damages the endothelium, it still damages the kidney function, the cerebral function, and the cardiac function. So it's not only the upper orange line, it's not only when the cutoff values of defining hypertension is reached that it is associated with cardiovascular diseases, but it is also when it is slightly elevated. And we define hypertension in 3 stages. So when there is like elevated blood pressure or stage 1 hypertension, that's even before like the clinical cutoffs of hypertension that we know occur. So even when it is not hypertension, but also not very normal, like those slightly elevated blood pressure are associated with an increased incidence of cardiovascular events within the next 20 years. And it is not new information also that hypertension is a modifiable risk factor. So we have benefit, and the patient has benefit of it if we diagnose it when we treat it. So when the treatment of hypertension with every 10 millimeter mercury reduction in systolic blood pressure, there is a quite large decrease in major cardiovascular event, coronary artery disease, stroke, heart failure, and all-cause mortality. And this is actually a quite consistent finding over the range of many other studies, and not only when hypertension is diagnosed. So even at the lower cutoff values, with each decrease of 10 millimeter mercury, you have a decrease in all these cardiovascular endpoints. So very important risk factor to be considered for proactive screening, but also for early treatment. So let's get back to our clinical problem within pregnancy. So the preeclampsia, and this figure of Satar, I love it because it helps me to come forward with the concepts that we've been working on the past 10 years. Because like the lower line, which represents the normal pregnancy or the non-hypertensive pregnancy, it remains below the threshold for developing a clinical cardiovascular problem. There's a large cardiovascular reserve. So with the changes in pregnancy, those women remain below that threshold, and eventually, as when they have to live long enough, but eventually they will cross that line. And that in contrast to those women with a vascularly complicated pregnancy, where you see that already in pregnancy they cross the clinical threshold for a cardiovascular problem. A second pregnancy is often less severe for the cardiovascular system. And these women, they develop their problem around 10 years earlier than a regular woman without pregnancy complication. And as you can see here, there's a large phase after delivery in which they are not ill because they didn't cross the line, but they're also not healthy because they have a lower cardiovascular reserve. So they develop a problem here in pregnancy, and they develop a problem there. So what happens in between here? Is there a phase that we could define where we could still interfere as cardiovascular clinicians to prevent that from happening? Well, you guys, you do your work within pregnancy, obstetricians, but is there a phase after delivery that we could work on? So we thought, let's understand how the physiological processes, the cardiovascular changes happen and occur during pregnancy. What happens there? And then later we try to understand what's happening here. So during pregnancy, all those cardiovascular changes, they occur in as a consequence of many changes that are happening within the placenta, within the uterus, and that have also a systemic effect. And all those hormones and endocrine circulating substances that are released, like relaxin, endothelin, PLGF, VEGF, eNOS, they all have a direct effect on the vasodilatory effect on the vasodilatory function of the arteries, but also on the venous system. But there's also they also have an effect, among other neuroactive effects, on the desensitization to the vasoconstrictors, angiotensin II, and norepinephrine. They're all the AV shunts they open. The sympathetic activity has an effect to decrease the baroreceptor sensitivity and decrease the neurovascular transduction. So all these neuromolecular effects, they trigger a complex cascade of cardiovascular changes. So we thought to, through a meta-analysis, to assess how do those cardiovascular changes occur during a normal pregnancy in order to define when is it abnormal, and could we see also those abnormalities happening even before the clinical situation of preeclampsia occurs. And we did that through a whole series of meta-analysis. Many bright, talented young students, PhD students, they worked on it because we had a hell of a job to do. There were so many articles based on every variable that we wanted to assess. And just to give you an example, on this article on plasma volume, where we started with 28,000 articles and then ended up with 94 articles. And what is very important to mention here, because I don't want to do this for all these meta-analysis, but I do want to stress that the reference values that we came up and the graphs that we came up, what we were interested in is not only the changes at certain cross-sectional time points, but we were mainly interested in the delta. So we took each woman as her own control. So we were interested in the changes that each individual woman would make through pregnancy. And we defined those changes, whether they would be normal if the course of that pregnancy was normal, or abnormal if the course of that pregnancy was abnormal. So let's start here with the total vascular resistance, in which we of course know that during a normal pregnancy we see a drop in total peripheral vascular resistance, which was also shown by this meta-analysis, and it is like around 200 dynes per second per centimeter, which is quite of a drop, and the largest decrease happens between 15 and 21 weeks of gestation, but it already starts so very early within pregnancy. And in contrast to that, we see that the peripheral vascular resistance, because now red is the hypertensive complicated pregnancies, we see that there is also a drop within the first 21 weeks, but this drop was significantly lower than the normal pregnancy. And after that, you see that then the peripheral vascular resistance starts to increase, but initially there is a drop. So before the complication becomes clinically obvious, so before the diagnosis was performed. And when we look at the systolic blood pressure, we were curious that mid-pregnancy blood pressure dip, does that exist? And well, our answer to that is, well, yes, it does exist.
Sorry. Walaikum assalam.
Well, it does exist, but it was just 2 millimeters mercury. So yeah, there was a significant mid-pregnancy drop, but the clinical relevance of that, well, we have our questions in whether you would really notice that in the clinical practice. Well, I'm quite well impressed by you obstetricians noticing that drop already in your clinical practice, because we as cardiologists, we fail to notice that such a drop normally in our practice. So what happens during the hypertensive pregnancies? Of course, that's not very hard to figure out once the diagnosis was made. So after the 20 weeks of gestation, like we see clearly that the blood pressure is increased in this category. Well, which is, of course, it fits the diagnosis of that problem. But what we also see is that before the 21 weeks, there is no mid-pregnancy dip, and it starts directly to increase afterwards. So plasma volume is quite an interesting field, which we have been working on for 20 years, and I'm aware that not many clinicians or researchers are aware of it. But what we do in our hospital and with our study cases is that we measure plasma volume by infusing ionized iodine, and then we know the concentration, and then we take the concentration out of the blood and measure that over the time course, and then we can extrapolate it, and then we have like the plasma volume of the specific patient, and we use that in our models and in our research along with other cardiovascular parameters to assess the risk of developing preeclampsia. So, and we are not the only one, of course. There are many others who did it and still do it. And what you see here, the plasma volume, that was why we were so interested also in the plasma volume, is that in a normal pregnancy, there's an increase in 1.1 liter over the course of pregnancy, and it also starts within the first trimester, and it reaches its peak around 28 weeks of gestation, and later on it flattens. So there's a 45% increased risk in plasma volume expansion. So how is that during preeclampsia? Well, it was very obvious that the increase in plasma volume was much lower. So it is 0.8 liters, which was 32% of change. And it was quite interesting to see that there were no studies at all before the clinical stage of preeclampsia. So we couldn't see what happens here before the 20 weeks of gestation with that plasma volume. Do those women already have a lower plasma volume and then they stay lower over the course of pregnancy, or do they start at the same point, increase normally, and then they have like plasma volume leakage, capillary leakage, or do they start the same but they just fail to increase their plasma volume? So these are quite interesting hypotheses that we are like working on to try to answer that question. So many hemodynamical changes, but how does it affect the heart? So I tried for just to make a schematic overview here. This is what we already discussed. In a normal pregnancy, there's an increase in volume load and there's a decrease in pressure load. We saw the blood pressure dropping slightly, but mainly the vascular resistance drop. Both, they do affect the adaptation of the heart in the same way during normal pregnancy as they do in people who do a lot of aerobic exercise. So the heart changes in a similar way. Well, during preeclampsia, there's also an increase in volume load, but the delta increase is lower, so the change is lower. And what we saw is that pressure load is higher, so vascular resistance increases and blood pressure increases. And before I continue in how this affects the geometry of the heart, I want to give you an insight in what we normally measure for the geometry. Well, you have the right ventricle on this side. Can you see my mouse? Yeah, okay. You have the right ventricle, it's often smaller than the left ventricle, and the septum in between is the interventricular septum, and the thickness of it is the first that increases when blood pressure rises. So the interventricular septum thickness. Then you have the posterior wall of the left ventricle. It also increases eventually, but normally in a later stage than the interventricular septum. And then you have the dimension of the left ventricle, and then the left ventricular and diastolic diameter is what we often use to measure the dimension and define the geometry. And then the formula is just to show you that we use these three variables to assess left ventricular mass. And then when we index it for body surface area or for length square 2.7 in pregnancy, then we have our index to standardize it. So the left ventricular mass defines whether we're talking about hypertrophy or not. And then there's another formula that is to assess whether the hypertrophy is eccentric or concentric. And what we then do is 2 times the posterior wall defined by the dimension of the left ventricle. And then we can say, well, we can see that, or if the relative wall thickness remains equal, the whole heart increases relatively in the same way, or we say the wall increases more than that the dimension does. And when do we see concentric or eccentric. I will show you in a minute because pregnancy is the most beautiful example to show that. I will show you what happens during a normal pregnancy. The mass increases, yeah, so only almost 30 grams, so the left ventricular mass, this formula, the whole heart increases, and the relative wall thickness remains almost the same. Yeah, 10%, that is not much if you know the values of relative wall thickness. So actually the dimension increases and the thickness of the septa increases equally. But what happens during preeclampsia is that the left ventricular mass increases much more, 100 grams more. That's actually like almost a steak that you can eat. That's quite a lot in cardiac terms. So it doubles the left ventricular mass, and the relative wall thickness also increases by more than 50%. And that's actually a pathological way of remodeling, which we know from heart failure. So let's come back to this graph again. I showed you until here. We have like those hemodynamic changes in normal pregnancy, similar to aerobic exercise. We have an increase in left ventricular. So both the increase in volume load and increase in pressure load lead to an increase in left ventricular mass, and relative wall thickness does not change much. So this leads to eccentric remodeling. You see it here in the hall, and we know it from normal physiological exercise. So this is actually quite a very sufficient way of remodeling of the heart. And we are very happy with that as cardiologists, because it starts to work more efficiently when you have such an expansion of plasma volume, which you need to let it circulate, because it decreases the end diastolic stress on the left ventricular wall. And you could also see it in animal studies that the sarcomeres are strained in series to each other, which is a very effective way of hypertrophy without increasing the stiffness of it. So you don't have a lot of fibrosis, and you don't have a lot of collagen. And in contrast, during preeclampsia, based on especially the increase in pressure load, so you don't have only the increase in volume load, but you also have a higher pressure load towards which the heart needs to pump. So it is reflected in the remodeling of the heart, because we see that the left ventricular mass is doubled, relative wall thickness is increased, and here you can appreciate the thickness of those left ventricular mass, and we see this from hypertensive heart disease. So this remodeling, we see it from hypertensive heart disease, and we see it as in the context of heart failure. And what you can see is that the sarcomere, which is like the unit of the heart that contracts, is not attached in series, as you can see here, but it's attached in parallel. And this attachment need a lot of collagen, need a lot of supportive tissue, and supportive tissue is not reversible as much as the hypertrophy in general of the cardiomyocytes. So after a normal pregnancy, in general, the cardiac geometry is recovered, but after preeclampsia, it's often not the case. And what we see here, that in many cases, there is still impaired geometry along with the impaired diastolic function of the left ventricle, which we also saw during pregnancy. So the idea behind this is, would that be then the chain of the phase between the pregnancy or the complicated pregnancy, preeclampsia, and the later elevated cardiovascular risk? Would that be the subclinical stage of heart failure that we need to look for and try to prevent it, especially knowing that these women have a lot of also cardiovascular risk factor, that we know that they are related to cardiovascular disease even without having preeclampsia in between? So don't we need to look actively to this stage and those risk factors, and then try to prevent this cardiovascular disease of happening? And I'm looking here also to Esma to see if I still have time to continue. Yeah, okay. Thank you. So what we also did is to see, well, this cardiac remodeling, is it only happening like as a phenotype? Is it only because we are like looking into it with our cardiac ultrasound, or is there more going on? And what one of our PhD students did, she screened all literature on all microRNAs that occur in cardiac remodeling, and also that they are known to occur or change during preeclampsia, to see whether there's an overlap. And then what she found is that there were several microRNAs that are over or under expressed that are very much related to hypertrophy, cardiomyocyte hypertrophy, but also to fibroblast formation. So, and those are the microRNAs that we know separate from preeclampsia, that are very much like affected in heart failure. And we showed with it that it is more than only like a phenotypical change that that we could just forget after delivery, but there's also a molecular and genetic epigenetical signatures that's happening there. So there were several groups that looked into the development of heart failure B, which is the abnormalities that I showed in cardiac geometry. So which is the abnormalities that we know from heart failure, but without the symptoms. So the prevalence of heart failure B in women with preeclampsia was in one of our cohorts 25%, and that in contrast to a control group which was only 6 or 7%. And what we also did, we adjusted for all the other cardiovascular risk factors. So we adjusted for hypertension, metabolic syndrome, kidney failure, and preeclampsia remained significantly having a higher adjusted odds ratio for heart failure B. So it was not only the elevated risk factors, there's also an independent contribution of preeclampsia itself. And of course, we are not the only one. The group of Esma and Baski and Karen Melchior, they did wonderful work, like exploring the whole concept of heart failure B and diastolic dysfunction in term and preterm preeclampsia, and they show similar results, which was quite valuable for this whole field. So what is that stage B? And I'm aware that well, from the obstetric fields, it might sound maybe sometimes abstract. So there are different schools in heart failure. There's in general, there's the American school and the European school. And here in Europe, like we talk, especially in like the NYHA criteria and classifications. And there are some other classifications, but the American school, they talk in stage A, B, C, and D, which actually I'm more fond of because it gives us a stage in which we might be able to interfere even before the clinical symptoms occur. So what they are defining is that stage A means that there are risk factors for heart failure. Stage B means that there are structural alterations in the heart without the clinical symptoms. So it could be a decreased ejection fraction, but it could also be the left ventricular remodeling that we just talked about after preeclampsia. And then the stage C and D are those clinical heart failure stages that cardiologists see in clinical practice. And the progression from stage B to stage C increases mortality 5 times. So that actually stresses the case that it is stage B that we might be valuable to look into and try to prevent from its progression to C, or even try to remodel it towards stage A. So in this stage, the stage between delivery and the clinical the clinical occurrence of cardiovascular disease, there are some cardiac abnormalities that I think we should proactively screen for and try to treat it. And the treatment could be related to the cardiovascular risk factor reduction, but there's also now, because we don't know how to treat it at the moment due to a lack of randomized controlled trials to try to treat heart failure B or prevent heart failure C from developing after heart failure B. So what is now going on in the field is that there's a randomized controlled trial on the use of ACE inhibitors after delivery to assess recurrent or de-remodeling of the left ventricular mass and geometry, but also to see whether you can just reset the cardiovascular system and try to also affect the occurrence of recurrent preeclampsia. So as a take-home message after this talk is that consider that pregnancy has many implications beside the obstetric ones. Try to see it as a cardiovascular stress test. It gives you an insight on how the future will be for the cardiovascular health of a specific young woman, because when it gets complicated by preeclampsia, it increases the risk for cardiovascular diseases later in life over the whole spectrum of cardiovascular diseases. There's a high prevalence of undetected hypertension after preeclampsia. It is a silent killer and it is a modifiable one. 25 to 40% of these women have heart failure stage B, and we're now working on defining or working on randomized control trial to see how can we change that course and admit those women to regular CVRM so cardiovascular risk management to prevent later cardiovascular diseases from happening. Well, we have a large group in Maastricht of very bright researchers and nurses and young doctors. And since a year, I made also the step towards Erasmus Medical Center, and our team is also expanding there to cover up over a large range of the Netherlands. And we have also a whole panel of patients that help us with defining our studies and also to see what are the questions that are so prominent and living in their experience to try to help them with our studies. Thank you very much for organizing this session and for all of the attentions. And I'm giving the word back to you, Esma.
Well, lovely. Thank you very much. Really, really comprehensive, and actually, it's really nice that you simplified it to an audience of obstetricians and gynecologists. I really like the way that you describe the concentric hypertrophy and the difference between what happens in normal pregnancy compared to what happened in preeclampsia. That was wonderful. Thank you very much. I'm conscious that we do have actually many questions from the delegates, and I also have a number of questions that I would love to discuss with Fabrizio and Shahinda. So I'm thinking I'm going to sort of decide to start the discussion now, because we obviously are conscious of the time as well. So maybe just going to start with Shahinda. It's something that you mentioned at the end of your talk about the ACE inhibitors. And the fact that there are ongoing randomized controlled trials, so women who develop preeclampsia, so postpartum, you're randomizing them to either ACE inhibitors or placebo, and looking at whether you actually manage to reduce their cardiovascular risk. Are you aware of which studies are are ongoing? Are you aware of any preliminary results? When do you think they're going to report? Because often the question is always, okay, identify this woman at high risk. What are you going to do to them?
Yeah, well, there's obviously there was a proof of concept study also in the UK performed, and what they found is actually that there was a slight increase in the left ventricular mass in these women, and it was feasible. Women wanted easily to participate, and there was also a decrease in blood pressure over the time course. And actually, they included early onset preeclamptic women, and we, of course, they're expanding it now to make it larger. And in our case, the randomized control study that we are doing is not only fixed to women who just delivered. So it is over the whole course after delivery until 25 years postpartum, because we still think that even until then you have the window to improve their cardiac geometry. So not only in the postpartum period.
Okay, so from sort of the practical point of view, so if a woman who develops preeclampsia, how do you manage this woman after the delivery? So I think most of the people who are listening to us, most of the delegates they tend to be clinicians.
Mm-hmm.
So if they have a preeclampsia, how do you counsel them? What's your proposed postnatal follow-up?
Yes. Yeah, very, very important question. Well, with the current knowledge, the least that we can do is after they finish from obstetricians in the Netherlands, it's at 6 weeks. I think it's very important to at 6 months to do a cardiovascular assessment, not to wait much longer. So after those 6 weeks, at 6 months to do that cardiovascular assessment, and it should and it needs to include like measuring blood pressure, but also cholesterol level and glucose, HbA1c. So a complete cardiovascular assessment that general practitioners and cardiologists normally do in patients with diabetes after 6 months, at 1 year, and then yearly. So the question remains, when do you have to do cardiac ultrasound? I think that many groups or clinicians might have different opinions on that, and which is quite understandable because we don't have like an evidence-based follow-up based on the cardiac ultrasound. But the least that you can do is to perform a cardiac ultrasound in the first year. So, but after 6 months, but within the first year, and then to repeat it after every 5 years, because and that next to the standard cardiovascular risk assessment, because the cardiac geometrical alterations might be if you manage their blood pressure well, then the 5 years of progression might be suitable to to have that window without expecting major things to happen within that time being.
Okay, so and therefore when you follow them up, if they have high blood pressure, obviously you treat it.
Yeah.
What will be the cutoff to start?
Yeah, that's a very good question, of course. The current, if you consider the SCORE models in our guidelines, the cutoff for women who are like young, the women dealing with, are quite high. They are above the 160 because their 10 years risk on mortality will always remain low. So the cutoff, based on the guidelines, current guidelines, would be for the systolic blood pressure around 160. But that's, you have in the guidelines, you need to look into all the paragraphs that gives you also space to reclassify women to other risk classifications. So if in general a woman, based on the fact that she's not smoking, has an age of 35 and all aspects is defined as low risk, and then you need to treat it starting from a systolic blood pressure of 160, then you have many other options to reclassify her and make her higher risk. And in my humble opinion, having had preeclampsia, it gives you that space to reclassify her as being high risk. That's one thing. Another thing is if you perform a cardiac ultrasound and you see left ventricular hypertrophy or concentric remodeling, that also gives you the ability to reclassify that woman. And that means that you need to target a blood pressure below 135, so below the pre-hypertension cutoff values. And I think that's also a trajectory that we are going more and more towards, and which is being much more acceptable to target a blood pressure below 135 systolic.
So you aim to maintain the blood pressure less than 135 over 80.
Yeah.
5.
Yes. In the 80, yeah.
80.
Yeah.
And therefore, if their blood pressure is above 140 over 90, you start antihypertensive treatment. You're not going to wait to 116.
Yeah.
Okay, perfect. I'm sure we're going to come back to it because there's some question, but I'm going to go to Fabrizio because there are many, many questions for your talk. Clearly, is a very important area. So there is a question from Fuseye. In women in whom the first trimester screening has been missed, would you recommend screening with SFLT1 BLGF, and if so, when? So they didn't have first trimester screening. Let's say they came at 20 weeks. What screening can you offer them?
I think the best way to manage these patients is to do screening at 20 weeks, and then you can use uterine artery Doppler. If your uterine artery Doppler is the mean PI is below the 95th centile, it's very unlikely that it's develop preeclampsia. If above the 95th centile, increase the risk. The false positive is very high, but this is the way to do the screening, because at 20 weeks I can define the way that I'm going to manage this patient, right? If uterine artery Doppler is normal, I'm not going to book a growth scan for this patient. If uterine artery Doppler is raised, I'm going to book a 28 and 36-week growth scan and recommending a close monitor of blood pressure.
And would you start her on aspirin? So if actually the risk seems to be high, so if she has an abnormal uterine Doppler, would you start her on aspirin?
It's a big question. I think that we have randomized clinical trials that did that and then show that aspirin didn't work very well. On the other hand, if you go to the Paris meta-analysis, that the classical meta-analysis about the aspirin, that the mean dose of aspirin was 75 milligrams. That's very low. We have to use over 100. In the mean gestational age that they started aspirin was over 20 weeks, 21 weeks. And then showed a reduction in around 18% in the rate of preeclampsia. Probably is because it's not acting the trophoblasts, it's probably protecting the endothelium. If I'm saying things that doesn't make sense, please correct me, Shahinda, in terms of action of aspirin. At 20 weeks, I still prescribe aspirin. Over 20 weeks, I don't prescribe anymore. But I think it's so important for us to start before 16 weeks.
Yeah, absolutely. And Shahinda, do you screen for preeclampsia in the Netherlands? Do you screen like first trimester screening and so the algorithm and national screening program?
Yeah, well, the Netherlands is quite a complex situation in which, like, we have a lot. We have two systems dealing with pregnant women. We have the midwives, which is like a separate entity from the gynecologists, and they have everything in control from in their hands, and they follow up with regular checkups, but they are only getting referred once there are problems. Which is often quite too late, and we had rather seen it being different. And Professor Spandeman, which you also know very well, of course, he tried to work on that for the past 10 years, but unfortunately it failed in the first line. In contrary, when there is a situation of a high-risk women or high-risk women with like a familiar history, or who had a preeclampsia in a previous pregnancy, or who have pre-existent hypertension, they are already admitted to the second line at the gynecologist, and then there are well, screening programs, and they have a strict follow-up in the second line.
Okay, and therefore at the moment there's no national screening program for the first
Not
trimester.
at all, no.
But you've got the program to follow up these patients.
Yes, we do have a program to follow up on them, and that's a program that we set up. We started to set up in 2015. And in that program, we screen all women at 6 months postpartum comprehensively with a complete cardiovascular risk management setup, so the regular ones, but also, and that we do it once, a complete thrombophilia, a plasma volume screening, cardiac ultrasound, and a CT of the coronaries. And then after we did that for 10 years on a cross-sectional base, and since this year we also started with a follow-up program. So we defined for every and every abnormalities when it is abnormal, what should we treat, what targets, and when the follow-up needs to be done, and we communicate that to their general practitioner, who does then the follow-up.
And is that funded by grant, for example, because in the UK we don't have that funding?
Yeah.
And often these patients are not really our patients anymore. They're not really obstetrics and gynae. They hand it over to the general practitioner, for example. Obviously, your team is fantastic because you actually have cardiologists. And is it like mainly research through a big, large research grant?
Yeah, it started with a research grant. So in the first 10 years, we didn't get any cent out of the insurance. So it was all insurance grants, and now we have a situation and that's because of the collaboration, because of the gynecologists and, well, us cardiologists, that we have a CVRM, like there is in the Netherlands we work with DBC, so it's a package for a certain health program that you give to the patient, and that package is you cannot do it as an obstetrician. You cannot do a cardiovascular risk management after, well, so many months post delivery, but we can do it because we are working together. Then you have like a multidisciplinary team, and then you have a special package, and based on that we get our financing from the insurance.
Okay, fantastic. That's great.
Shahinda, I'm very jealous.
Yes,
like UK,
too.
Australia doesn't have this kind of
We don't
program.
have that.
We have the recommendation here, I think that's similar in the UK, for the patients to be seen by GPs 6 weeks after birth. But very few of them, they do it. The GPs, they don't have the information. They don't follow up after preeclampsia and after gestational diabetes as well. I think it's the two main pregnancy complications that can generate high risk for complications later in life. Really missing that.
Yeah, I totally agree. It wasn't also very easy to set it up here because there were not many cardiologists who are really very interested in this problem, because they're still not sick, right? They will have a heart attack after 20 years and then they become interested. And also the general practitioners, they were not very aware of, but it took us around 10 years to set up this program and get people motivated to work all together.
Yeah. I mean, I think also when we tried years ago to set up this, and I think that not all the patients used to come because they're busy with the baby.
Yeah.
And therefore, I think maybe the very, very early onset severe, where they will actually potentially come, but actually the one that had like a preeclampsia term, mild, they're fine. They often don't come to the follow-up appointments. I'm going to go back to Fabrizio, because you were one of the first people actually that really looked at the ophthalmic artery Doppler with your team in Brazil and published the initial studies. Someone asked, who will do the ophthalmic artery Doppler?
Sounds very different for an obstetrician, right? But actually, it's very, very easy to be done. We can teach general obstetricians, general sonographers to do that. The technique sometimes is more simple than to do uterine artery Doppler in a patient with high BMI, for example. Someone in your center that knows how to do it. If you have to follow the technique. We published a few years ago an opinion paper in the White Journal, if you want to go there. I think that was 2016, that you are describing the technique. It's very easy to do it.
Yeah, absolutely. I mean, and you actually did cover that in your talk about how easy it was the probe. But you need the linear probe, not the curvilinear probe that
Yeah.
we can.
Yes, it's the linear probe.
I mean, there's some practical questions about sort of the cutoff. So if you do it, what would be the cutoff to say it's abnormal?
I think the whole idea of multifactorial screening is not having cutoff, right? You don't have cutoff for uterine artery Doppler, you don't have for PAPA PLGF, you don't have for MAP. Actually, you're using as a continuum, and you have to have the algorithm. The algorithm is not clinically available at this point in time. There are some assumptions that the new Fetal Medicine Foundation software that will be launched hopefully soon is going to have ophthalmic artery incorporated on that. I think that we have to wait to have the algorithm instead to use a cutoff. Cutoffs, they don't work well. You have to use the multifactorial approach.
Yeah. So, and therefore, on its own, I guess you can't use it at the moment. You need to use it as a part of a prediction model.
Yeah.
The sort of Lata, I think Lata is asking, she's, if I believe it, that's that Lata who I know, she says there's overwhelming evidence of early prediction of preeclampsia, the first trimester screening. Why is not routinely used in all hospitals? I mean, I can mention about the UK, but and I think Fabrizio, you have successfully obviously implemented, or you've got like a recommendation. So you've got guidelines saying you should, I guess, in Australia. But my understanding that in Australia, not all hospitals are at the moment. They're not.
No, it's not. I think that this is the major difficulty, and is my main challenge here, is to have national implementation. The Australian health system is quite fragmented. We have federal, that's GP based, but the hospitals they are state based, and 30% of our patients they are private. My hospital pays for it because I convinced my CEO that's cost effective. But there are basically particular initiatives. There are 4 public hospitals in Australia at this point in time offering that. The grant that we obtained a short time ago was to do this national study in 8 maternities with the aim to inform the Australian government for broad national implementation. We put a business case together. We have an entity that is similar than the UK that's called MSEC. If I want to propose new technologies or new medication to be paid by Medicare, you have to put a proposal. We put a proposal together. This proposal was analyzed for over 2 years. And late last year, Medicare declined to support national screening for preeclampsia. They want more information, believe it or not, about aspirin. It's a bit of unbelievable, but we are going to provide this information. Of course, cost effectiveness is important as well. We already showed in Australia that's very cost effective. Doing this screening in 2 public hospitals over 2 years, 6,000 deliveries, was possible to prevent 30 cases of preeclampsia and to save 1.5 million of Australian dollars. I think that's having more evidence on boards. We hope to convince government, but we need a group of people keen to do that and locally show that it works, shows cost effectiveness, and try to convince your politicians to implement that. Is a quite big task.
Yes, I know. And maybe talking, I mean, Lata said if you are the Lata, I know. They're actually talking about the UK. So the UK, where actually most of the evidence about first trimester screening and aspirin originated from, the National Screening Committee reviewed the evidence and they recommended not to screen for preeclampsia. So not to do first trimester screening for preeclampsia. And the rationale behind this recommendation or this decision is the fact, as Fabrizio mentioned, is that most women who develop preeclampsia, they develop it at term. And therefore, in terms of numbers, is the first trimester screening for preeclampsia is not very good for term preeclampsia. And this, despite the fact we think it's a benign condition, it's not. These women have high risk of morbidity, but for the mother and for the baby, and therefore they wanted more evidence on screening and prevention of late preeclampsia. Hence, there is a lot of focus now on term preeclampsia. I think to some extent the preterm and the early preeclampsia, it's there. There's first trimester screening. There is evidence of aspirin to prevent it. I think is where the numbers, in terms of population point of view, most women who develop preeclampsia develop it at term. And this test is not good for term preeclampsia, and therefore they wanted more research. I mean, you might not agree with them, but that's a rationale.
Asma, if I may just comment about that, I think that this is really true. This is the reason that was not accepted in the UK. In Australia, it was a little bit different. I believe that the way for us to convince governments is having an approach that you're using first trimester screening for preterm preeclampsia and 35, 36 weeks screening for term preeclampsia when you have more evidence on board, and you're scanning the patients 3 times during the pregnancy. At 12 weeks, at 20 weeks, of course, for the morphology scan, and then at 36 weeks for a prediction of late pregnancy complications and to define the best time of birth. I think that this comprehensive approach, of course, you need more evidence to show that it works, but I think that this is the way that is possible implementation, let's say in the next 5 to 10 years.
Yeah, absolutely. And hence that probably addresses the next question from AK. Which patient to screen for prediction of term preeclampsia? I think what you probably implied is that all of the patients should have.
It's all of them.
Yeah.
I think that's the best approach at this point in time. Is someone is high risk for preterm preeclampsia and didn't develop preterm preeclampsia. Of course, if develops preterm preeclampsia, delivering at 37 weeks or before, if there is a maternal or fetal indication, right? But the ones that they didn't develop preterm preeclampsia, again, we need a randomized clinical trial to show that this is really true. But we have some observational evidence that if I'm delivering these patients at 39 weeks, we can prevent around 30% of the cases of term preeclampsia. Now we need to screen everybody at 36 weeks to define a high risk for term preeclampsia and doing the same approach that you be timely delivery to prevent term preeclampsia.
Yeah. Okay, so thank you very much. Is the fact that when do you stop aspirin? Because I think one thing that we published is that giving aspirin to women increase the risk of postpartum hemorrhage, increase the risk of intrapartum bleeding. Also, there is some evidence from the large Swedish registry that also increase the risk of neonatal intracranial hemorrhage. So, and therefore we tend to stop aspirin about 36 weeks. Is that what you do, Fabrizio?
Yeah, this that I do for the reasons that you mentioned. Aspirin is a drug, has side effects. You publish Asma a quite nice paper showing that the risk of hemorrhage for vaginal delivery for cesarean section increases. And as you mentioned, there is this Scandinavian study that showed that there is an empirical risk of brain hemorrhage of the neonates. If I'm giving for everybody, I'm increasing these risks. And there's a couple of randomized clinical trials that they showed because the uptake of the patients, the adherence to aspirin, if I'm prescribing for the whole population, is very, very low and then doesn't work. I have to do a screening to select a truly high risk group because of that. And then I stop at 36 weeks because of these reasons.
Yeah, correct. Shahinda, I think there's some question about small babies, and I think you obviously, you know, the title of your talk was about preeclampsia, and I think this is your current beautiful follow-up program. Will focus on women who have developed preeclampsia. Preeclampsia, as you know, is very closely associated with fetal growth restriction of small babies. Why don't you follow or offer this program to women who have small babies but not preeclampsia?
Well, actually, there are several reasons for that. The first one is that it took us already a huge amount of effort to set up this program for the highest risk women. So we started first with women with early preeclampsia, because that's what we could convince our like funding organizations of, and later our hospital. Later we extended it to women with, in general, preeclampsia, so early, late term, preterm, and we also extended it to women with gestational diabetes. We provide a different program to that. So and women with small babies, I think that's a broad definition, because it could have several and different reasons and etiologies behind that, and not only the vascular ones. So then you need to define clearly only the vascular related small baby pregnancies. So I think that's the main reason, and we don't have the capability for that now, but probably in the future. But it would be something additional to do once you could define it very well. And I think you are the best to help in defining this group. But at this moment, we are very happy that we could provide the screening programs that we have now for the highest risk populations, which are those with preeclampsia, I think.
Yeah. Okay. Well, yeah, Fabrizio, go ahead.
May I ask
yes.
Sorry. May I ask a question to Shahinda?
Yes.
By the way, I loved your presentation, Shahinda. It was really, really nice.
Thank you so much.
In terms of antihypertensive drugs to prescribe during the pregnancy, we do that empirically, right? And we are not personalizing that. Do you think that you can use cardiovascular parameters for personalization of the drugs that you're using?
Yes, well, I love that question, of course. Yes, I do think that we need to do it differently. We need to do it hemodynamically based. So now we do it indeed empirically. We published an algorithm 2 years ago, because how we do it in Maastricht is that we measure hemodynamics over the course of the first 20 weeks of gestation in high-risk women. And then we look up for the ratio between peripheral vascular resistance and cardiac output. And we have an algorithm based on that. So when the vascular resistance is high above the cutoff and cardiac output is low, then we prefer a calcium antagonist, nifedipine, for example. And when it's the other way around, we prefer a beta blocker. And we define a gray zone in between, in which like methyl dopa would be the way to go. And we do that already now for, I think, 7 years. We published our first data based on that. Obstetric observations, of course, so it's not randomized controlled trial. And we showed a reduction of 50% of recurrent preeclampsia, because all those women that we did it in were women who had it already in the first pregnancy. So we showed a reduction of 50% in recurrent preeclampsia without any negative effect on the fetus. And now we have the medical ethical committee approval to do it in a randomized setting, and we will start with that at the beginning of next year.
Fantastic, amazing. I mean, it's like your team are doing fantastic research in this area, and very methodologically robust and quite systematic approach. So I really look forward to, hopefully next webinar you'll have some results to share with us, or maybe we'll ask you about talking about this topic.
This specific topic, I would love to.
That would be lovely, because I really think is that we at the moment we just have a blanket approach, is it? Well, what we should do is to have more sophisticated, individualized risk assessment, individualized treatment. But in order to do that, you really need to have several studies, large studies, and proper prediction models has been validated. So the other thing about small babies, I mean, the truth is that the majority of small babies are actually, they're just constitutionally small. So just a small baby on its own is really a very, very poor marker of placental insufficiency or of even maternal cardiovascular dysfunction. So, and therefore you need to really identify the placental fetal growth restriction rather than just small babies. And hence, one of the questions about the incidence of small babies with fetal Doppler in normal gross fetus. So actually the performance of the prediction of the first trimester screening for small babies is actually quite poor. It's not very good because the majority of small babies are actually completely just constitutionally. And therefore first trimester screening for preeclampsia does not really perform very well for first trimester screening for small for gestation age. Do you agree, Fabrizio?
Yeah, this is really true. We are just going to publish a paper. It's the final round of. Actually, I was just accepted. That's validating the Fetal Medicine Foundation screening for SGA to the Australian population. Fetal Medicine Foundation detection rate was only 55%. For the Australian population, is 50%. It's very poor. It's not possible to put in clinical use. If someone's high risk for preterm preeclampsia, of course, is high risk for SGA fetal growth restriction, and 70% of the cases they are related with preeclampsia. The challenge is to make the difference. If you're doing a scan and you have a baby below the 10th percentile, if this is a constitutionally small fetus or is placental dysfunction, right? We need more data, but I'm using routinely S3 PLGF to help in this differentiation. If the ratio is low, if below 38, it's extremely unlikely that this placental dysfunction is more likely constitutionally small. We are planning to do an audit because this is retrospective data to publish this, and I think that other centers are doing a similar approach. I really, really believe that the combination of course, fetal size and fetal growth, together with Dopplers and together with the ratio or PLGF, you'll be quite useful to define that. And I showed you before some publications that we are doing with Sailesh Kumar, that you are using the ratio or PLGF in fetal growth restriction, and there is a major correlation with timing of birth, and also in fetus adequate for gestational age. There is certain degree of placental dysfunction, even in babies with normal growth, that the ratio or PLGF can detect that, and then this relative gestational age of delivery.
Yeah. I mean, I agree with you that antigenic markers are really useful, but and I think that's a question from Egil about is it necessary to do the ratio if it looks like only PLGF is working well in the prognosis of preeclampsia? So you beautifully illustrated that actually in the first trimester, S-FLT1 PLGF, the ratio is not useful. Only PLGF is useful. I think the issue with PLGF is the cost. And I think one of the question about if I can do triac Doppler, but I cannot do biochemistry, for example, is that can it be good for prediction, for example, if I can't do the biomarkers?
I think the soft-ophthalmic artery Doppler is the one that's equivalent to the blood biomarkers. It's not umbilical artery or uterine arteries. Is the ophthalmic that could be complements to UA and uterine artery doing ophthalmic. I think it's the way that you are moving from now on. But of course, we need the algorithm to be available for us to use that.
Yes, and actually, it's one of the questions about. I mean, there is a lot of interest in ophthalmic artery Doppler about what gestation would you measure it, and there is data on the first trimester, there's data on the third trimester. So I think you're at the same time as when you do the screening, whether you choose to or opt to do it in the first trimester, third trimester, there is data on ophthalmic artery Doppler. And therefore we'll see whether that will be incorporated. So if you can't have the biochemistry because it's quite expensive, biochemical markers, that you could alternatively do the ophthalmic artery Doppler, which costs you nothing, just to be able to have a linear probe that can do the ophthalmic artery Doppler. Again, Lata, many questions. Urinary Congo red, is it useful validated tool in screening for preeclampsia as point of care test?
I think that we need more publications about that. We don't have enough data. There's one paper that showed, or a couple of papers that showed that could be interesting. But to be honest, I'm not seeing many publications lately about Congo rats. I don't know if you're familiar, Asma, with new things. We didn't test here in Australia. I think that's not progressing. This is my feeling about that. What's your experience?
I think absolutely. I mean, I agree with you that I think there over the history, there's been several biochemical markers that's been proposed to be associated with the risk of preeclampsia, and I published loads of them. But then they either not validated, or maybe the performance is not optimal to be introduced, or when you put them in this logistic regression or prediction model, they're not really that useful. They don't add value to what the component that you have already in the prediction model.
Yeah.
So urinary Congo rate, I think, is one of them, unless there is sort of more evidence or maybe more research or to suggest that it's a promising marker. At the moment, I don't think it's one of the top, or one of the one that being proposed to be introduced into clinical practice. I think there's one question about arterial stiffness, and certainly I spent quite a significant chunk of my career studying arterial stiffness in preeclampsia, and we published on arterial stiffness in women with preeclampsia, and before the onset of preeclampsia, for prediction of preeclampsia. And yes, it is obviously a marker for prediction of preeclampsia, but is it very good to be included in a prediction model? And the answer is not, because to some extent blood pressure, trunk Doppler, VLGF, other markers that are included in the prediction model at the moment, as well as ophthalmic Doppler, are likely to perform better. There are many questions.
You mentioned, Asma, a big point. There's a lot of things associated with preeclampsia, right? That they are up and down. There's hundreds of different markers, but if they are, they are not independent. They are dependent. They are basically measuring the same thing. And a marker to be useful has to be independent. If I'm putting on top of the algorithm that I have to improve this algorithm. And they are extremely rare markers, right? This is the reason that, of course, it's still important to do research about novel biomarkers. I have a large group doing that here, but it's very difficult to find novel biomarkers. We are quite onto RNA. Actually, I think that RNA is quite promising. We hope to have some papers coming out in the next 1 to 2 years about RNA.
Oh, quite interesting. I totally agree also with both of you. And when it comes to endothelial of vascular stiffness, it is also, we need to look into measures and biomarkers that we could measure also directly, which are, as you said, also mentioned, are less interdependent. And like vascular stiffness is it's still quite difficult to measure. And it's like a derivative of many other variables that, also are maybe performing even better in all the models. So it is quite interesting and very valuable to keep doing those studies, because I think there's also a link in which women will develop problems like preeclampsia and what women won't. So it is a very interesting and important link for the future. And to understand the basis of that. But I totally agree that it is, I think, not the way to go for prediction.
Yeah, because if you think that VLGF is expensive, I think mRNA is much more expensive. But I wonder whether actually, because women who develop preeclampsia, they increase risk of long-term cardiovascular disorders. But the truth also, Shahin, that the majority.
Mm-hmm.
So, and I think what you're doing when you're sort of following them up is triaging, is it? So identifying the one that will develop and the one that will benefit from in prevention or intervention. I wonder whether the mRNA, because mRNA probably to some extent reflects your genetic predisposition. And it might be actually a good tool potentially. I mean, it's just theoretical. This needs to be proven to actually identify those who will have the heart attack, 20 years down the line.
Yeah, well, microRNAs, there was a period that they were really very promising, and they were also in the field of heart failure. There were so studies, millions of euros, like being spent on those studies. But actually, within the cardiovascular field, there's a drawback, and one of the reasons for that is they're quite variable. They are like messenger RNAs in between, in a certain stage or phase of the disease progression might be elevated and then later downregulated. And so I'm not yet really convinced that microRNAs are the way to go. But were you talking about microRNAs, Fabricio, or RNAs itself?
I'm talking about, we have some data about microRNA, and I presented at IJOG in Budapest that we are able to differentiate preterm preeclampsia and term preeclampsia. There is a microRNA a signature for both.
Yeah.
Of course, was a small population study. We have to increase the population size. But I completely agree with you. There's a huge variability. There's a huge population variability. And you have a lot of players with mRNA and all the interactions with gene expression, right?
Yeah.
It's quite complex.
Yeah, yeah, that's true. And actually, that's also the point that you mentioned, Esme, that most women won't develop cardiovascular problems after preeclampsia. And this is also a very interesting point that we focus on societal basis, that we don't want to scare all women, but we do want to keep them aware because their risk is elevated. And in this context, I do believe in a certain HIT model, which we also know from, for example, peripartum cardiomyopathy or dilated cardiomyopathy in other cases, that some women, they might have a genetic predisposition that are prone for one hit. So maybe in those cases, like pregnancy would be that extra hit that makes them prone for later problems. And other women with other genetic predisposition might be prone for 2 hits. So like preeclampsia and one of those risk factors. And we're still not there to define them. But we have now in the cohort that